Let's talk about another group of patients, and that's the performance status 2 patients. I think most oncologists probably see at least a third of their practice with non-small cell having borderline performance status or so-called performance status 2. This trial was brought to us by Dr. Lillenbaum, who 10 years ago presented the CLGB 9730 trial, which had a specified performance status 2 subset analysis. You see highlighted on the right of this slide are the differences in median survival and 1-year overall survival in favor of using carboplatin 2 drugs versus single-agent paclitaxel. So this was a 1 versus 2 drug evaluation in a planned subset analysis for PS2 patients. You see it was in favor of using 2 drugs versus 1 drug. This trial was not necessarily considered definitive. It had about 100 patients, and this was a subgroup analysis, not the primary endpoint of this particular trial. So the next slide shows the trial design for the trial that Dr. Lillenbaum presented at ASCO. Again, this was advanced staged patients, the old 6th edition staging system, performance status 2, previously untreated, adequate organ function because of the pemetrexed on this arm. You see the stratification factors. This was a balanced randomization. Patients received either single-agent pemetrexed for 4 cycles versus the combination of carboplatin and pemetrexed. Interestingly, they gave 4 cycles. No maintenance therapy was planned in this trial. And this trial was done before the histologic issues with pemetrexed were recognized. So there was a small percentage of squamous patients, as I'll show you on a subsequent slide, entered onto this trial. The primary endpoint was overall survival in this particular design. Here are the patients, about 100 patients per arm. You see the median age was 65 on both arms. All of these baseline demographic factors were well balanced. 80% of the patients had adenocarcinoma histology, but 3 to 10% on the both arms. You see this was not statistically different, and I don't think clinically significant in terms of the difference between about 11% and 3% squamous histology on the 2 arm. Most of the patients were smokers, although 20% were never smokers. We always struggle with why patients have a poor performance status. Is it because of the cancer or is it because of comorbidities? That question was actually asked of Dr. Lillenbaum at ASCO. And his sense from looking at the comorbidity analysis was that this seemed to be a population and that probably had performance status 2 based upon having the disease rather than having a myriad of comorbidities. Here's the response data, and it almost exactly mirrors the CLGB trial that I showed you on that introductory slide, 10% versus 24%. This was statistically significant. There was a bit more toxicity on the 2-drug arm versus the 1-drug arm, and I think it's important to note that there were more grade 5 events. So we do take a risk of patients having more toxicity. We have to be aware and careful of that. When you look at the progression-free survival here, it was approximately doubled in favor of the 2-drug versus 1-drug arm, and a very impressive hazard ratio of 0.46. I don't think you need a p-value on this curve. These curves separate early in favor of 2 drugs and are really actually quite impressively separated over the duration of these curves. Similar effect on overall survival, median of 5.6 months versus 9.1 months, more than a doubling of the survival at 1 year and a hazard ratio of 0.57. Again, statistically significant, and I don't think we need a p-value to tell us that those curves are very clinically meaningful to physicians who treat these patients. I've actually used Dr. Lillenbaum's conclusion slide from ASCO for my conclusion slides, and I did that because I agree with these things. I think these results can be generalized to PS2 patients of all histologic subtypes using appropriate combination regimens. I don't believe this was an effect that was specific for pemetrexed. He encouraged organizations that have guidelines to consider this data and to revise their guidelines based upon this and other data sets that suggest that in patients with performance status 2 who you believe that this is largely related to their disease, that to being more aggressive in terms of the number of drugs used, this 2 versus 1, improves outcomes in these patient populations. Now, this trial was done almost exclusively in Brazil, although Dr. Lillenbaum in Miami did reference to this particular trial. I think the other important thing about this, although we didn't dwell on the slides and the data, was that this was a trial that established the fact that one could do investigator-initiated multi-center trials of high quality in developing countries. And I think this is of great credit to the organizers and authors that presented this data at this year's ASCO.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our GRACE website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.